date with us. I was stating earlier that knowing how to do the wash fit assessment is a continuation of the presentation of last week. Last week, we are informed on how IPC is the software and wash is the hardware you need to implement infection prevention and control at any healthcare facility. So today we have a seasoned IPC practitioner, a consultant, who will be taking us through the wash fit assessment. So I have the pleasure of introducing to us this afternoon Dr. Damilola Adeniyi, who is a public health professional and infection control consultant at the Center for Infection Control and Patient Safety, also known as CCAPS. He has competencies in project management, policy formulation, leadership development, team science, and capacity building. He also serves as the Infection Control Africa Network West African Hub Training Coordinator. Dr. Adeniyi coordinated the pilot of the novel USCDC Environmental Cleaning Program Toolkit at the Lagos City Teaching Hospital in 2021, aimed at implementing best practices within the facility. His work on environmental cleaning and the Toolkit pilot has led to presentations on multiple platforms, such as the ICANN Conference, Infection Control Society of Southern Africa, which is ICSA, United States WASH in Healthcare Community of Practice, amongst others. Dr. Adeniyi has set up IPC programs and facilitated several IPC trainings for both public and private institutions, such as the NCDC, Lagos State Ministry of Health, the CAF Medical Laboratory and Maternity Center, and the Lux Dental Clinics, among others. His commitment to improve IPC practices in Nigeria has led to his participation in validating the National Patient Safety and Care Quality Policy and Strategy and Legal Needs Assessment for IPC Legal Framework Development in Nigeria, among other IPC guidelines. So permit me to welcome now Dr. Damilola Adeniyi. Lisa, you have the floor.
Thank you very much, Dr. Jembi, for that very generous introduction. Good morning, good afternoon, good evening, depending on where you're joining from. The world is a global village now, so you could be joining from anywhere. Thank you, NSIC, for this platform. Please, can you give me rights to share my screen? Please enable me to share my screen. Thank you very much. We're going to be talking about the wash fit tool, which is a sequel to the wash in healthcare facility presentation that I held last week. I think I had the privilege of joining part of the presentation, which was quite rich. Please, can you also confirm if you can hear me, just to be sure that I'm not speaking to myself, and confirm if you can see my screen. Thank you very much. Can you hear me and can you see my screen?
Yes, we can hear you, sir.
Yeah. Okay, thank you. Thank you very much. Please also confirm if you can see my screen on slideshow.
Yes, also we see.
It's not on slideshow yet. It's not on slideshow yet.
Slideshow.
Okay, just a minute. Okay. It should be now. Can you see my screen on slideshow?
Yes. It's on slideshow now.
Okay, thank you very much. Now we have just a few minutes to go through the wash fit methodology. But the truth is, wash fit is at least a week-long physical intensive training. So what we'll be able to do in the next 20-25 minutes will be to scratch the surface, at least to give us basic understanding of how to conduct an assessment and also improvement, because the wash fit is a tool that not only helps you to assess, but also to improve water sanitation and hygiene within your facility. This is the outline I'll be making use of. an introduction to wash fit. We'll look at the purpose and scope of wash fit. We'll talk about the 7 wash fit domains and then the steps of the cycle itself, which comprises 5 steps. And then we'll look at the key outputs and the tasks for each step. A nurse in the Philippines in 2019 made this statement, just as a testament to how effective the wash fit tool is. Before starting wash fit, I thought the way wash services were managed and their hygiene practices passed on to me by previous health workers from the facility were acceptable and that nothing had to be changed or improved. After setting up the team and conducting the assessment collectively, we identified many items that needed improvement, such as the clogging of drains, increasing ventilation, staff training, amongst others. These are things we can do ourselves that benefit the staff and the clientele we are serving. Then she goes on to say, the time will come for me to be transferred to another facility. I can hand over the facility to the next health worker together with the wash fit plan that he or she can use as the baseline for further improvement. Again, just a testament to the importance of the wash fit tool. So by virtue of introduction, the term wash fit is actually an acronym. We know that wash means water, sanitation, and hygiene. The fit is a facility improvement tool. So by inference, the wash fit tool is a tool that helps you to improve water, sanitation, and hygiene services within the facility. It is a quality improvement tool that helps you to strengthen wash services. And we know that wash is a critical part of quality of care. And wash is very closely linked to IPC. And for those that are IPC practitioners, you know that IPC is impossible without wash. And we often would say that for you to achieve the software of IPC, you must have the hardware of wash. In other words, water, sanitation, hygiene facilities, amongst others, must be in place. The wash fit is a planning and implementation framework that you can adapt to suit your context. We'll, look at how the tool works. But it's important to say, ab initio, that it is not cast in stone. The tool allows you to adapt to your context, meaning that small facilities may not need to, go the whole 9 yards as far as the tool is concerned. So it can be adapted. And then it's even encouraged for facilities that are extremely large, like tertiary facilities. You can actually introduce some indicators and some line items you would like to assess that are in keeping with the national plan or policy within that country. Of course, it goes without saying that the wash fit tool supports IPC and it encourages collaboration across different groups. We'll see that shortly. Sometimes to define what something is, you also have to define what it is not. The wash fit is not an assessment tool. It's not just an assessment tool. It is an improvement tool. So there is no point doing an assessment if we're not ready to improve. Like I said, it can be adapted to context. So it's not a one size fits all tool. And it's not something you complete in a day. It takes a long time to actually go through the wash fit process. Most people would say that it would take a minimum of about a month to 3 or 6 months to go through the entire cycle. We'll talk about the 5-step cycle shortly. Speaking about this, the purpose of the wash fit tool, amongst other things, the wash fit tool helps us to increase quality of care, by extension, increase the likelihood of others seeking care. It also helps us to improve the morale of our staff and their performance. It improves IPC and antimicrobial resistance, antimicrobial stewardship, which is to reduce AMR, and then reduces the level of pollution. We'll talk about some of the environmental cleaning components. And it also helps to be more efficient in the use of healthcare resources. Looking at the scope of what the wash fit helps you to improve, we'll speak about the domains very soon. But the wash fit tool helps you to improve IPC, like we said earlier. Wash is a core component of minimum requirements. If you remember the 8 minimum requirements of IPC, the 8th component is actually the built environment. and wash is a key part of the built environment. The wash fit tool also helps in outbreak response and resilience, helps in the quality of air, environmental sustainability, and climate resilience. And then you probably would have been hearing a lot about gender, equity, disability, and social inclusion, known as GETC for short. In the process of planning and improving wash services, one of the things that is very critical is the ability to ensure that people with disability and then factoring in the peculiar needs of both genders, you have to consider that when you go through the wash fit cycle. So these are some of the areas where the wash fit helps you to improve. Speaking about the domains of wash fit, there are 7 domains. Now, not every facility of necessity would, assess all the domains and improve across all domains. So just like we said, it's the tool can be adapted to your context. You may decide to focus on certain domains. Traditionally, before the more recent edition of the wash fit was developed, I think somewhere around 2019, 2020, you had water, sanitation, waste management, hand hygiene, and environmental cleaning. The last 2 domains were added after them, energy and environment, and then management and workforce. And so you may decide to do an assessment and, consequent improvement across all these domains, or you may decide to focus on the more traditional domains. And then even in more recent times, there's a lot around, climate and energy, things around that. But like I said, we just want to stick to the basics for the sake of this presentation. Yeah, so 2 additional cross-cutting themes are, climate and gender equality, disability, and social inclusion, like I mentioned earlier. So let's go into the process of the wash fit. There are 5 steps in the wash fit cycle. When you think about implementing an IPC program, for example, say a hand hygiene program, the steps are pretty similar. The first step is that you establish the team. All right, and there are things you need to consider when you establish the team. Who are the people that should be in the team? We'll talk about that shortly. And then you train the team based on the wash fit, methodology, because the team, everyone on the team is meant to be involved in going through the process. The second step is that you do an assessment of the facility. Now, the wash fit, provides a tool whether it's on Excel, there's the Excel option, and there's also the Kobo Collect option that allows you to assess the 7 domains like we discussed based on based on the standards that are required. If we have the time, we may be able to look at maybe an example of what the Excel sheet looks like, but the presentation has snippets of the things that are on the Excel sheet. And so you assess the facility under water, under sanitation, under hand hygiene, under healthcare waste management, and under environmental cleaning, based on the standards that are provided. For example, questions around, does your facility have an improved water source? And an improved water source is clearly defined. And so you respond, yes or no, and then that would inform some of the potential problems that you may need to address depending on what your response is. Step 3 is to now do a risk assessment of the gaps you have identified, the areas where there is a need for improvement. You have to be able to do a risk assessment to prioritize what you consider as a high risk or medium or intermediate and then low risk. And by extension, usually you have to focus on the high risk areas for improvement. Step 4 would involve developing a plan, an improvement plan, after you're prioritized and taking action. While step 5 entails the monitoring review of the process and then improving on whatever accomplishments you've made within the first cycle. So this is a summary of step 1. We said step 1 is to establish a team, and then train the team on the wash fit document. And so a team has to be responsible for wash fit. It is not a one-man show. And so it's the responsibility of the wash focal person or the IPC focal person, depending on the facility, to select those that will make the wash fit team. Now, the team, it's important that the team comprises of people across different, aspects of the hospital, not just limited to the clinical areas. For example, you want to involve, if you have wash engineers or the engineers, you want to involve a representative of the policymakers or those in management or administration to ensure that there is representation across board. And then this team needs to meet regularly, to make decisions, to do the assessments, to decide on the improvements, drafting a plan amongst all of this. But what is critical here is that it is the team that becomes the driving force for all of the wash fit activities, and then training the team on how this needs to be done is extremely important. Some people, rather than train their wash fit team directly, may go as far as taking the team along for a larger training that is more intensive. But bottom line is there has to be a team, and the team has to be trained. These are summary pages. I'm going into some of the details as we speak. So when we get to the detailed slides, I may skip some of them. The second step is to do the assessment. Like I said, there is a template that gives us the standards for you to assess your facility across the different domains. And when you assess the facility, there are scores, that automatically will be assigned to each item you assess, and then you end up with a wash fit score. And then your facility can be classified into different cadres depending on what the score is. The idea of the assessment is that you want to identify where there are gaps. And it's in the areas where there are gaps, you then do a risk assessment subsequently. But typically, when we look at the cycle of assessment, assessments are often repeated within 6 months to a year. Step 3 involves the risk assessment for areas where you have identified that there are gaps. And then you have to be able to classify, the gaps based on the severity of the problem attached to that gap, and also the likelihood of occurrence. We'll look at that in a bit of detail, and then you come up with a total risk score. And depending on what the score is, you then rank the problems you have identified from the highest to the lowest. Step 4 is how you develop an action plan or improvement plan. So based on the problems you have identified, you then develop an action plan, which includes specific steps you want to take, the people responsible, the resources that are needed, the time when the intervention should start, and then completion dates. These are the things that constitute a detailed action plan. And then step 5 is for you to review what you have done from step 1 to 4, have meetings with the relevant stakeholders, and then you gather data, and then you recheck what the improvements you have made over the period of your assessment and improvement. So let's look in a bit more detail at step 1. In establishing your wash fit team and training them, there are 2 key outputs. First is there has to be a team that will be responsible for the improvements. And the team needs to have clearly defined roles and responsibilities. The team needs to meet regularly to assess, progress, to assign tasks, to track progress and things like that. And then documentation of the meetings is extremely important. So we often say what is not documented is not done. So the team is as important as the documentation of the meetings. And this is important because of sustainability, such that when you want to commence another cycle, you have documents that can guide you on how, the previous, cycle went. Tasks, as far as step 1 is concerned, would be for you to identify the people that should constitute your wash fit team. And they're not just limited to hospital staff. Some settings you want to involve community members that have the necessary expertise in your wash fit team. Of course, you need to conduct regular meetings and then train those on the team. Now, these are 2 different scenarios depending on your facility of what a wash fit team might look like. For a primary healthcare facility, you have a doctor, clinician, or whoever is the facility lead. And then you want to have a nurse or health assistant. It could be a nurse and a healthcare assistant depending on how large the PHC is. It's important to have an engineer or the technician within the facility or the community, and then have a community focal person, and then have a representative from the local government or the district, depending on what nomenclature um, you know you use. And then for secondary or tertiary facilities, you have more representation on things like having members of senior management, a member of senior management or members depending on what's appropriate for the setting, having a wash engineer, having the people in charge of waste management. The bottom line is that you need to consider the different domains that you'll be assessing, and that can inform, those that will be part of your team and the expertise that you will need. So these are just examples of what worship teams can look like. And then just a few things to note in establishing your team. You want to document whatever is done, you want to meet regularly. It's important to appoint a leader. Sometimes the IPC focal person, which in this case is possibly somebody on this call might be the leader, or you may decide to assign. It's important to have diversity in your team. And so you want to make sure that, it's not a team of just men. You want to have, female representation. You want to have a blend of clinical and non-clinical staff. And then you also want to have community representation. Step 2 is the assessment itself. The outputs are an adapted version of the assessment form. Now, at the beginning of this presentation, I stated that the wash fit methodology can be adapted to your setting. All right, so it's important to go through the tool ahead of time and you decide, okay, so what are the things, what are the domains we want to assess? So you can decide to adapt it to reduce the domains depending on your facility, or if you want to add a number of indicators. Of course, the form needs to be completed. So a regularly completed assessment and record of previous assessments to compare progress. So records of previous assessment would mean if there has been a wash fit cycle before the one that is currently ongoing, you want to compare that with what you currently have. So what you do is that you use the template to answer the questions for the different domains, and then you review and adapt the assessment form to your context. Now, in terms of what we use for the assessment, like I said, there's the Excel sheet. I think if we have the time, I'll show us what the Excel sheet looks like. There's also the Kobo app, which is it's almost like an access document that you basically just put in the details, and that is particularly phone friendly. So it depends on which one you want to use, and there are people that have even adapted the tool into their own personal apps that may not be necessarily Kobo or Excel. And so the structure of the assessment form is such that there are over 90 indicators, I think about 96 in total across the various domains. Not all indicators will be relevant for all facilities. And then the scoring system. So this is a classic example. Under the healthcare waste management domain, you can have a question that says, you have a question that actually says, waste is correctly segregated at all waste generation points. If the answer is yes, at all points, emphasis on all, you tick yes, the score automatically will be 2. If there's some sorting done at some points, but not all points, then it partially meets the criteria, that becomes a 1. And if waste is not correctly sorted at any waste generation point, that's a 0. So that's just an example of what the assessment looks like for one of the line items under one of the indicators. And so you answer questions across the various indicators and domains. In adapting the assessment tool, it's important to align your indicators with national standards. And so, it's important to, so for example, if there is a WASH framework, a national WASH guideline, it's important that you adhere to what your national guideline is, regardless of what the wash fit tool says. And then there might be a need to change scoring criteria to make it more achievable or to be more aspirational. So bottom line is that the tool can be adapted. If you are in a smaller facility, you can decide to reduce the number of indicators that you want to assess and then improve, or remove the ones that are not relevant. For example, if you don't have inpatient services, or maybe an incinerator or waste treatment. And then for bigger facilities, you can decide to start the wash fit cycle on one word, one unit, one department before you do a full assessment. And then you can also focus on the specific wash domain. You can decide, okay, want to focus on water and environmental cleaning, for example. Bottom line is that the tool can be adapted. In scoring, in calculating your total score, you put together for the various domains. If you're using the Excel sheet, automatically it will calculate the total score for each domain. And then on the summary page, you see the various scores showing up. But if you have to calculate, depending on what you're using, it will be total score of all the indicators assessed over the maximum possible score. And then this is the classification for facilities. Any facility that has less than 67% is considered poor. The one between 67 and 75 is average, and then above 75 is good. Pretty much, similar to how hand hygiene self-assessment framework works. So what this does for you is that it helps you to be able to track progress between multiple wash fit cycles. Step 3 is conducting a risk assessment. This sometimes can be a bit technical for people who are endeavor to maybe slow down a bit here. But the idea is if you're using the Excel sheet, when you've done your assessment, automatically what happens is that there is a tab that shows step 3 to step 5. And then the areas where there are gaps, would show up. And then you have to now identify what are the problems associated with the gaps you have identified. For example, I used the waste segregation question earlier. If waste is not segregated at the point of generation, what is the likely problem that is associated with that? And so you put that in on that tab. And then there is a need to assess that risk, that potential problem that results from that gap in 2 areas: the severity of that problem and then the likelihood that that problem would occur. So severity, there is a scoring based on your judgment, based on the team's judgment between 0 and 10. You put a score. Likelihood of occurrence, you put a score. I'll show us an example of a few problems that were done. And then you end up with a total risk score. Now, that is done for the different areas where there are problems. That allows you to be able to stratify or prioritize the areas where improvement is needed. So that's, just to summarize how step 3, works. So the outputs are that there has to be a list of problems and gaps you have identified. And then you need to understand the risks that are associated with each of those problems. And then you rank those risks based on their severity of occurrence and the likelihood that they would occur. So this is a table that shows how to calculate the risk. So for example, remember I said there are 2 categories you're looking at: the severity of the consequence of that gap and the likelihood that that problem would occur. And so if you consider it to be low severity, meaning there are no major health effects that are anticipated based on that gap, you can then score it somewhere between 0 and 3. If you think that it is likely that there will be moderate negative effects, maybe discomfort, unsatisfactory services such as not being pleasant to the eyes, odors in the facility, or working conditions that are not favorable, or minor injuries, that is medium severity. You score between 4 and 6. But if the problem you have identified is likely to lead to major injuries or infection to patients, to staff, or even perhaps disability, then that is high severity. You score between 7 to 10. And then in the area of likelihood of occurrence, if a problem is likely to occur, but only rarely, you score between 0 to 3. If a problem is somewhat likely to occur, between 4 and 6. If it is a constant problem, an ongoing problem, or a problem that is very likely to occur, you score between 7 and 10. And then what happens is that you add the severity score and the likelihood of occurrence. And then, of course, the maximum you can get is 10 and 10 on both sides, which is 20. So when you add both scores, your total score, if it falls between 0 and 7, is low risk, meaning that there's minimal harm to humans, to the environment. Then you have medium, which is 8 to 14, and then 15 to 20 if it would lead to significant harm amongst humans or even the environment. So having done the risk assessment and calculated the risk score, it's important to prioritize the items for action. So you sort the list of problems according to the risk score. You go from the highest to the lowest. And of course, the problems with the highest risk are the ones that should be prioritized for urgent action. Lower risk scores should also be addressed subsequently when resources become available. And then sometimes some problems that have a low risk score, may only require simple interventions. And so you may decide to go ahead with improvements in those areas. This table just shows how to prioritize according to level of risk. Like I said, low, medium, and high. This is after you've calculated the total risk where you put together severity and the likelihood. Now, the ones with the low risk, you can address as resources become available. And then action action in such a case means that you can address them with usually with either low or low cost actions. But if they are not addressed, meaning if there's inaction, it is unlikely to result in major cost implications. The reverse is with high risk. They need urgent attention because they lead to severe damage, or they are very likely to occur. So it's important to prioritize them. So often the action to deal with this would require significant time, expertise, and time resources. But the cost of inaction is also very often severe or serious. So this is an example. This is a classic example of doing a risk assessment for certain problems that have been identified. So no improved water supply on premise is an example. The severity of the risk that is associated with that, this is an example of the scoring of it can be 9 out of 10, which means that the severity is huge. And then the likelihood that those problems will occur is, in this case, 10 out of 10. So we have a total risk of 19. So when you compare that to lack of lighting in the toilet, for example, you see that potentially lack of lighting in the toilet doesn't carry as much risk as not even having water at all within your facility. Just give us a sense of how the risk assessment goes. Step 4 is the development of an improvement plan and taking action. The outputs for this include an incremental improvement plan with time-bound activities that are set and agreed by the team. Of course, it has to be endorsed by senior management. And then timely action on activities as listed within the plan. Now, remember that you have prioritized the actions that are needed to be taken based on the previous step. That should be step 3. You have prioritized the actions that are needed. You have prioritized, the risk. Sorry. And so what you do is that in developing a risk plan, you specify the action that needs to be taken. So what action is needed to address this gap that we have identified? And then you identify who is going to be responsible, what resources do we need. So human resources, technical or financial resources, estimated budget, of course, and then the timeline for completion, the start date, and then the end date for the action plan. So the principles of a general action plan actually, come here when it comes to the wash fit. So these are just examples of improvements that you may suggest. You may decide that, okay, training is needed for maybe staff in the area of a particular department, or to focus on maybe hand hygiene or focus on one aspect. You may decide that we need to review protocols, or we even need to develop SOPs if they don't exist. You may decide that you need to build the infrastructure. It depends on what gaps that you identify. And we know that simple low-cost improvements can have a big impact, but may require some imagination and creativity. And that's why having a team that has good representation and also trained, comes in, because sometimes you just need simple solutions to solve supposedly big problems. These are examples also in step 4 of some of the improvements that can be made in the area of waste, healthcare waste management. Immediate improvements that have minimal cost may include training the staff, ensuring you have reminders at the point of care, or training them on the rational use of PPE. Medium-term improvements will mean perhaps you want to build a low-cost incinerator, or you want to build a temporary storage that can be locked for waste. And then more long-term or more expensive solutions might be you developing a centralized plan, that doesn't involve burning in terms of waste management. So just, a few examples of improvements you may decide to come up with. Step 5 is to monitor, review, adapt, and then improve what you have previously done. The outputs for this will include regular meetings of the team and senior management. So it's important to, identify here that it helps to have somebody in management on the team. But when you get to step 5, you engage more with management, all right, or relevant stakeholders, so that you can discuss the progress you have made. So you look at where you started when you did the initial assessment, and then you look at the improvements you've made. Sometimes the improvements you have on the action plan, by the time you get to the completion date, you may not have been able to achieve that. And so you may need to review, those plans. Of course, regular review of progress and modifications of the worksheet methodology sometimes will be needed. And that regularity is dependent on, the team or your context. It can be 6 months, every year, or even longer. And then data is very key. So worksheet data being shared with the facility, and then even at district or local government level, or even at national level. Every 6 months, it's recommended that you conduct assessments, and then you recalculate the worksheet score. Remember, I mentioned 6 months to a year. And so that helps you, that gives you a sense of how much progress you're making and how the facility score has changed since the last assessment. Gives you an idea of how much improvements have been made. And then it also means that when you want to commence the next cycle, you can decide to focus on other areas. And so you need to ask questions like, which domains or which indicators are scoring less well, and why do they have less scores? Do we need to get external help? Do we have the capacity to address, some of these areas where there are gaps? So these are some of the things that step 5, helps you to assess. And so the worksheet tool, is a quality improvement tool. Like we said, it's not limited to assessment. It helps you to improve. It's a tool that helps you to improve water, sanitation, and hygiene services within your facility in a bid to have better and safer care. It's actually a tool that involves analysis of processes, outcomes, and all of that. And then it involves, everyone working together. We've talked about the different steps, the 5 steps of the worksheet tool, establishing a team and ensuring that that team is trained, and then doing an assessment of wash facilities across the various domains, and then doing a risk assessment of the gaps you have identified during your initial assessment, so that you can classify them into high risk, medium risk, or low risk based on their severity of the problem and the likelihood that it will occur. And then going ahead to develop an incremental improvement plan, which specifies what exactly needs to be done by whom, what resources, and what timeline. And then finally monitoring, adapting, and improving, reviewing and improving what you have done previously. So these are materials that we can access online to get a lot more. Like I said, this presentation pretty much just scratches the surface. And for further reading, these are some of the links. Thank you very much. I'd like to turn it over to the NC team for any questions and answers. Thank you.
Thank you, Dr. Damilola, for that wonderful and explicit presentation. So as he said, if you do not plan to improve, there's no point using the wash fit, because it is a tool for improvement. And he also let us know that we have 7 domains, and there are various scopes that the wash fit assessment tool can help us improve. IPC is just one of the scopes. The other scopes were outbreak response, quality of healthcare, and environmental sustainability, which are all very important areas. So using the wash fit is like using one stone to kill like 6 or 7 more birds. So you can see this is a very important assessment as the gains we cut across various aspects. I think I can see, was there a hand I saw up? So we can take questions from participants. Did somebody have a hand up? Okay, so as I was saying, so we can say that the wash fit is a very important tool, and it's something that for us to have standardized or working IPC programs, we have to address wash in our facilities. And this tool will enable us assess our current state of wash facilities in our healthcare institutions, and then develop an improvement plan to ensure that we improve from our current state to the desired state, which will further on help us implement IPC properly. So do we have questions from participants or comments before we go on? I'm aware that Dr. Dami has another meeting. He only took out time to come and give us this presentation. If we have questions from the participants, can I see raised hands, or you put your questions in the chat? So while we are waiting, I would like to ask Dr. Dami, being a Nigerian and having an idea of what the healthcare facilities are, what do you
Yes,
think?
I'm here. I'm
Okay,
here right here.
okay. What do you think would be the best approach in trying to implement this, typically at any healthcare facility?
Okay, well, I think it depends on the facility. It depends on what level of facility you're looking at. I believe in the concept of piloting things so that you can, on a small scale, envisage challenges before you move to a larger scale. And so, what I would recommend is that for those that are really interested in doing a wash fit, going through the wash fit methodology, you can start by focusing on um, a department, a unit, where it's likely that you'll get the collaboration that is needed, where perhaps you've had previous programs, that worked. Because after doing the assessment, if you remember that it is about improvement, that's why it's wash fit and not wash fast. Like some people will say, it's facility improvement tool, not just facility assessment. We want to make improvements, and it's easy to make improvements in certain areas where you can perhaps predict that the stakeholders or those that are involved, are willing to buy into what you want to do. So step one is extremely important. The failure of step one many times will mean failure of the entire cycle. You want to have the right people on board the wash fit team. And when we say wash fit team, so that it doesn't sound like you need, you may just need three people. I believe that the minimum is three, three or four, depending on what you're looking at. And so focusing on a unit or a department where it's likely that your improvements will prove through and you'll be able to accomplish those things might be a good idea. And then there are those that decide that, okay, for step two, which is the assessment, that they can decide, okay, let's do an assessment. We don't lose anything by assessing the whole facility. All right, so it gives you an idea of where you are based on the wash indices. And then you may now decide to streamline your improvements to specific wards, units, or even specific domains to say, okay, you know what, for this cycle, let's just focus on the water issues. Usually, water issues are usually very, very fundamental, and many times they would likely rank high in your risk assessment. And that's not, to de-emphasize the other domains. Or you can decide that, okay, from what I have seen, our percentage score for waste management is really low. Okay, so why don't we just, let's focus on waste management. And then waste management, you may decide to focus on waste management within a particular department or unit that you envisage that you will get the response or the support that is needed. So again, there is no one size fits all. It depends on the context. It depends on your own context. I hope that answers your question.
Yeah, thank you very much for that elaborate response. I think it brings it more into perspective. Patrick Ada, I can see your hand is raised. You can unmute and ask your question. Hello, Patrick Ada. You can unmute and ask your question.
Hello,
Yes,
good
we can hear
afternoon.
you.
I believe that the IPC team that set up this process, they have a vision of ensuring that our capacity is built, and I appreciate your commitment to results. I want to emphasize that at a policy level, is there an ongoing advocacy to bring in the federal government into institutionalizing programs that will ensure that health workers, whether at a contract level, skill-based attendants, or OIC, they have capacity to improve, to review, to put in more value into a system where, I want to quote what you said. You said it's not a one-man approach. So the teamwork, the resistance from the OIC to the SBA is partly a core part of the labor room. So we believe that safety standards for prevention control, it should be emphasized at MPs, MCPDP level, and then at government budgeting and planning level too. Thank you so much.
Thank you, Patrick Ada. Although I was a bit lost with all your acronyms. MP, OIC, FDA. So I don't know, but I don't know if Dr. Dami got you, but I was a bit lost with your acronyms. So I don't know if you can re-ask your question in a simpler form. Or Dr. Dami, are you fine with the way he presented it?
Yes, I'm fine.
Okay,
I understand it.
Okay.
Yeah, Patrick, it's fine. I understand the question. The question is actually not limited to the wash presentation. It's a more generic question as far as IPC is concerned. So whether there is a lot going on at policy level, at federal or even state level, yes, there is. There's quite a lot going on. At least I have the privilege of working closely with bodies like NCDC, a lot of the IBC stakeholders in Nigeria. So for example, there's a lot happening at policy level, whether it's with respect to the development of infection control, national infection prevention and control manual, or even in the area of legislation, trying to pass certain laws of ensuring that certain standards are met within facilities. Yeah, so but how far or how effective those steps have been, I may not be able to speak directly to that. But I believe in the concept of taking ownership. Um, while we wait for those things to happen at federal level and all of that, one of the reasons why we've set up a platform like this and one of the benefits of being a part of NSIC is that we understand that there's a lot of empowerment that can happen on an individual basis. And then with people with influential positions can cascade, that empowerment to those in their facility. Yeah. So to the aspect of the question whether people there is policy going on to empower facilities and then people within those facilities to be able to add value in turn. It will go into things like saying, um, is there a budget to train the staff in the area of IPC and all of that? I may not be able to speak on a generic level, but I know that there are organizations that provide grants and try to train IPC persons. I know NCDC, for example, is doing a lot in that regard to try to train. There's something ongoing presently to try to train healthcare IPC focal persons across the entire country, and the training in turn, will potentially lead to improvements within those facilities, and it will trickle down to other healthcare workers. So there's actually a lot happening, but the truth is that the gap the gap that needs to be filled is huge. And so if everyone will take their own part and be responsible in their own little way, we'll be able to fill that gap. Platform like this NSIC Echo allows us to empower people. And so now you know about WashFit, or should I say, we've been talking about WashFit for a few weeks now. Now you know that there's a WashFit tool. Even if it's not mandated from the head of your hospital, as an IPC person, can you carry out the WashFit cycle, the methodology in your facility or some aspects of the facility? Can you do an assessment? Are there areas where you can improve? Now, the improvement areas may not always be limited to what management has to do. Even as an IPC person, there are improvements you can make. So I'll give you an example. I showed you for waste management, I showed you what do you call it now? Short-term improvements, medium-term, and long-term. The short-term improvements are things that we can do at an individual level. Short-term improvements might mean training your staff on waste segregation. All right, you don't need a huge budget for that. You probably don't even need a budget for that. Ensuring that there are reminders at the point where waste is generated. So those are low-hanging fruits, that you can do something about. So it starts with us. That's the summary of my response. I hope that answers your question, Patrick.
So Patrick, are you fine with the response? But I think he has done a good job in addressing that. And one reason why in NSIC we brought up this topic following the IPC wash session of last month was because we understand that if some of these structural issues are not addressed, then many attempts on implementing IPC at facilities will fail. And as you rightly mentioned, the essence of this session is to ensure that we can build capacity and, if necessary, address what requirements we need to enable us use this tool at our various facilities. So I think this will take us to the next activity, which is asking these poll questions and seeing where most of us in this platform are. I think, let's see. So some poll questions have been put up. Can we all see the questions? So let's just answer yes and no. Then we'll use this to start another round of discussions. Can we see the questions? For question 1, that's referring to whether you are aware before this presentation. So if you are not aware before the presentation, please make it a no. So far, 6 people have answered. Can all of us see the poll questions?
It's no longer visible. Though I've answered, but it's no longer visible.
No, but we haven't ended the poll. I'm seeing it on my screen. Oh.
I'm no longer seeing it. Maybe because I've submitted back.
Okay. Other participants, can we see the poll, the questions?
No, please.
I can still see it from my end.
So what's going on? I can see that 9 people have answered. So some people actually still see. Maybe Those of you that can't see it, have you submitted? Will that be why?
I am also posting the
Yes, I
questions.
believe once you fail, it disappears because that's what happened here. I can't see mine anymore after I submitted.
Okay. All
Other
right.
people can answer the questions in the chat. I am posting the questions in the chat box. Please, you can share your answers there.
So maybe we'll go with those who have answered currently. We have 11 people have answered, have made responses. So Alina, okay, let's see for question 1, which is, are you aware of the wash fit? About 67% says yes, 33% says no. Then question 2, have you
Should
used
I
the
end the
tool?
poll, John?
Okay, people are still answering because the number has gone up to 12 now.
Okay.
Do we still give more time for people to do the poll?
Yes, maybe in 2 minutes, then I close it and share the result.
Pardon?
Maybe 2 more minutes and then I close the poll and show the results.
All right, that will be fine. So please, if you haven't answered, quickly do that. It's just a yes or no response. We want to use it as a baseline for the next group of discussions.
Maybe we can close now and share the results.
All
We have
all
70.
right, that will be fine. Thank you, Alina. Excuse me.
Here are the results, John.
Okay. So I should click stop sharing.
No, it's on the screen. You can discuss the results here.
All right. Okay. Thank you, everyone, for all of us who made time to participate. So more than half of us, we are aware of the wash fit tool before this presentation, about 69% from our participants. Then for those who have used the tool, I think only 8%, that is 1 out of all the respondents. So majority of us have not yet used the assessment tool. So even though most of us are aware of the tool, more than half of us, 69%, as it should, and only 8% have used it. Can I, at this point, ask 2 or 3 people that we are aware of the tool, but not used it yet, share their experience as in reasons why? Please, do you understand my question? 69% of us have used it, are aware of the tool, but only 8% of us have used it. So if we can have just 1 or 2 persons share with us that were aware of the tool and yet to use it, reasons why. So that way we can know how we can help improve things. It's like nobody wants to bail the cat. Okay, Kufri, you have your hand up. Please unmute and speak.
Okay, I've not used the tool because before now, I have not seen any will I say I've not know, it's recently I got to know about it, and I'm still trying to get used to it. And
Okay.
besides, they've been, when you don't have need for something, you don't you don't use it. I've been much conversant with the IPC tools, the IPC, the IPAC tool, the IPC facility framework tools, the hand hygiene framework, and all other tools. So WASH, I think it's just recently I got to know about it. And when I saw the Excel version, well, I'm still going through it. But even if I use it, what do I do with it? Uh, sort of. So though it's something I plan to use in future, because I was planning to do something like that so that I and my IPC team could look at our facility and see what we can improve on our facility with the wash tool. But we've been much conversant with the IPAC tool for IPC, which we've been using from time to time to improve ourselves on IPC. So that's my own reason.
Okay, thank you for sharing with us your experience. A few points comes across from what you have shared. You feel one, there's no need to. It also looks like you need some more experience or some training on how to actually utilize the tool. Because if you listen, just as Dr. Damilola showed us, using the tool, it acts like a quality improvement tool. It helps you assess why are you having challenges with IPC, especially structural issues, and then it enables you to develop an improvement plan. So by the time you now address those things, it now makes IPC implementation more seamless. That's why we refer to WASH as the hardware and IPC as the software in improving IPC in healthcare facilities. So it's not something that as an IPC professional or practitioner, you can do without. It enables you ensure that you improve on your hardware so that your software can work well. So we thank you, Kufe, for sharing that experience with us. Your comments and actually what you said is well taken, and we'll also use it in further implementations. So now the next question, do you have the required expertise to administer the tool? And we only have 8% saying yes. About majority of the people, that's 92%, said no. So this now lets us know that we actually have to plan or work towards a session where we can equip ourselves with the required expertise and know-how to use this tool, which will enable us overall improve IPC implementation. Then the next poll question. So before I move on, from Dr. Dami's presentation, we can see that there's a lot to be covered on the wash fit. So we will plan further on whether we are going to have online sessions or physical sessions to see how this training can be done. Then the fourth question, would you or your facility like to be part of an assessment using the wash fit? I think only one person said no, majority said yes. So the aim of this, as I said at the beginning, is for us to improve IPC at our facilities. It's not going to be like a fault-finding mission or anything. But we realize that for us to have our IPC programs work well, it will be impossible to do that without addressing WASH. And that's the whole essence of this presentation. So for us to improve WASH so that IPC can work, we now need to use the wash fit so that we can improve wash using qualitative and standardized methods and techniques. So since majority of us require training, we will, as a society, plan on how that can work, and then we'll get back to us at the earliest convenience. And for those who would like to be part of the assessment, we will send something that has been simplified that you can utilize at your facility. Let us have an idea of where majority of our facilities lie with respect to wash facilities or wash infrastructure. So with that at the back of our minds, we can even build a case on getting funding to enable us float a training session or float training sessions, physical training sessions for the wash fit assessment. So I hope we are all on the same page. Any other questions before we let Dr. Dami go? He has another meeting. So no hands are raised up. So Dr. Dami, are you still with us or you've already left? We would like to thank you for...
I think he
Pardon?
has.
Okay.
He
We'll
has.
thank him.
He's no
He
longer.
has gone. Yeah, he actually joined us from another meeting to give this presentation. So with your responses from the poll, we now know that we need to organize a session to improve our capacity and expertise in using the tool so that we can improve wash facilities at all our healthcare facilities, knowing that without good wash facilities, you can hardly implement IPC programs and get the required results that we all want, which is what? Improve healthcare safety. So at this point, we'd like to thank Dr. Dam, even though he has left us, for giving us this presentation, which, as he said, is just the tip of the iceberg. And it lets us know that we also have a lot of work to do. So the same way most of us are familiar with the hand hygiene self-assessment framework tools, the IPCAF, which assesses IPC at healthcare facilities, is the same way we hope that we'll become familiar with using the wash fit to improve our IPC programs and improve wash facilities at our healthcare facilities. So furthermore, I would like to ask those of you who have not yet registered with us to check in the chat box. You see a link that will enable you register, which shows the NSIC membership form. And once registered, you have access to all the resource materials that are presented during our sessions. Okay, some people put their answers in the chat box. Most people's, yeah. Do you require training? Somebody? Or if you have used the tool previously. So the questions are also put in the chat box. For those who did not access the tool on the poll, but the answers still reflect what we discussed on the poll. So going forward, we will get back to you with information on what we are able to achieve from this session and further planned trainings as regarding using the wash fit. Is the link for feedback in the chats? I haven't seen it yet. I can't find the link for feedback in the chat. Can you post it so that we can have feedback for these sessions? And as I said, please, we will send to your mails a simple tool to have an idea of the baseline assessment at various facilities so that we can use this as an avenue to ensure that we can organize training sessions on using the wash fit at our various facilities. So most people have said yes. So we know that that's another line to toe. Amy, I don't know if I'm the only one that is not seeing.
Yes, I'm about to.
Okay, thank you.
Okay, I just shared the link for the feedback form.
So you'll be getting a message in your mails with a modified simple tool so that can have a baseline assessment and use that to make a case for organizing a training workshop on the wash fit. So does any of our participants have any comments, questions, clarifications, or comments to make? You can unmute and speak.
The link for the feedback form is currently on the platform, on the chat box now.
So our participants, any comments on the wash fit that will enable us improve or modify our planning for training sessions? Oh, we're all happy with what I said. That's why nobody is saying anything.
Yeah, something like that.
Okay. So we send to your mails, then you give us your feedback. Then we use that to plan training sessions for the wash fit. But you can see that from Dr. Dami's presentation, it's not something that we can do in 25 or 30 minutes. There are various aspects to the tool, and we need to understand all the 7 domains and then how to put across the questions, utilize the checklist, develop action points by doing the risk assessments, and then deciding on how we can do our implementation to improve WASH. So it's not something we can do in 25 or 30 minutes, but this was just to introduce the tool and then see how we can plan further for more robust training sessions. So if you can kindly fill in the feedback assessment, I think we look forward to seeing you again, same time next month on one of our other sessions.
The flyer for the conference is here.
Okay,
I has
sorry, I didn't
projected it.
see it. Sorry. So before you go, thank you, Amaka, for the reminder. We are planning a conference in the first week of December, and the theme is institutionalizing infection prevention and control practices in healthcare delivery. It's to hold from the 4th, is it 4th to the 8th of December. It's hybrid. So the on-site is in Lagos, but of course you can join virtually from everywhere. We will also circulate the call of abstracts so that you can start sending in abstracts to share your various IPC experiences, and we can all learn from one another. So please keep this at the back of your minds and start planning to travel to be with us physically in Lagos or to join us virtually. Thank you, Amy, for the reminder. I actually forgot.
You're welcome.
So have we all done the feedback? And we look forward to seeing all of you again. We would also like to give huge thanks to Alina from Echo India, who is always supporting us during our sessions. And she has enabled us conduct this poll. Okay, some people are still working on it, so we'll give you some time. Enable us conducted this poll seamlessly. So Alina, thank you so much. We always appreciate the support we get from you, and we do not take it for granted. And
I'm happy to be here.
all right, thank you.